This is an interesting case which was referred to me for a second opinion. 11-year-old girl who had a history of trauma several years ago, followed by intermittent episodes of swelling in the maxillary anterior area. So when she came to me, this was her clinical condition. She had a very large lesion extending all the way from the canine on one side to the canine on the other side. And you can see both the central incisors had open apices and a very large lesion. CBCT shows you the extent of the lesion involving almost the entire maxillary anterior area. Because she had already been to several practitioners before coming to me, she had quite a few treatment plans with her. And when I glanced through these treatment plans, almost all of them were the same. They all suggested root canals in all the 6 anterior teeth, RCT in all the 6 anterior teeth, followed by surgery to get rid of the lesion. Now, this is a very radical procedure in my opinion, especially in an 11-year-old child. And the reason why a lot of people opt for this is because they tend to see these large lesions as a surgical problem rather than an endodontic problem. So the first thing we do when we get a case like this is we check the vitality of all the involved teeth. And this is what I did. And when I did a vitality, I found that the lateral and canine on both sides was actually vital. So the only teeth that were non-vital or non-responsive to heat or cold was the central incisors. So we decided to treat only the central incisors and not do anything about the lateral and canine for now. So I decided to access both these teeth and then do multiple rounds of calcium hydroxide, look for some sign of the lesion to heal, and then look at obturating both these central incisors either with MTA, or if we induced enough epexification, then we would look at obturating with gutta perca. So this is what I did. I started the case in September 2012. We went through multiple rounds of calcium hydroxide and followed this case all the way up to March 2015. So if you look at this case in March 2015, several months after we started the initial treatment, we can see that the lesions healed almost completely, and we also noticed there's a bit of a barrier formation both on the left and right central incisors. On the right central incisor, you can see there's evidence of barrier formation here, whereas on the left central incisor, the barrier seems to be somewhere here. So we decided to go back in there and check the clinical scenario. So I started with the right central incisor. I removed the calcium hydroxide, and then I inserted a gutta perca cone, and you can see that I could see that the gutta perca cone had a solid resistance in this area. So when I viewed the apical portion where the gutta perca was coming to a hard resistance, I could see evidence of a barrier formation there, but the barrier was not uniform. In one part of the barrier, I could see a bit of bleeding. So I decided, usually if I see a complete barrier here, then I would just obturate with gutta perca from an obtura gun. But because I could see that in one part of the wall there was a lack of continuity, I decided to place MTA there. So this is what I did. I put MTA, and when I took this radiograph, I could see a bit of radiolucency here. So I tried to push MTA in this part, but it just wouldn't go there. So what appears as a radiolucent area in the X-ray is actually quite a hard barrier. So I put MTA against the apical portion there, about 3 to 4 millimeters of MTA. I didn't want to take a chance and seal this coronal portion immediately. I placed a bit of cotton there and sealed this with a temporary filling so that I could go back in there, check if the MTA is hardened a few days later, and then do the coronal buildup. So that's what I did in the right central incisor. And then once I was done with that, I moved on to the left central incisor. I removed all the calcium hydroxide that we had placed there, and I found that in this tooth the resistance was felt somewhere in this area. So I viewed that area under the microscope, and what I found in this case was there was a uniform barrier throughout. There was no lack of continuity anywhere. You can see here the barrier is actually very continuous with the adjacent wall. So once I knew that the barrier was continuous, I decided to fill this with obtura with gutta perca from the obtura gun rather than MTA. So this is what I did. I extruded gutta perca And although it looks as though it's overextended, it actually isn't. This because the barrier is somewhere here. So I extruded cataperca about 5 millimeters, 5 to 6 millimeters, and then restored the coronal portion with a fiberglass post, a very large fiberglass post inverted, to give some additional strength because there's quite a bit of coronal weakening. That's what I did in that tooth. And as far as the other tooth is concerned, I went back in there about 4 or 5 days later and then removed the cotton pellet, checked and to see that the MTS was really hard, rock hard, and then I placed a fiberglass post to give some additional coronal strength in that tooth as well. So the obturation, post-obturation radiograph looks a bit odd because it looks short in this tooth, but it actually isn't short because that's where the barrier is. Whereas on the other tooth it looks long, but it actually isn't long because there is a solid barrier there as well. So this is how we started, and this is how we ended several months later. This is the CBCT. You can see how we started with a very wide open apex, and then this is how we ended with a really solid barrier, and also the entire lesion healing completely, bone being formed here. What's also interesting you can see is that although in the radiograph this obturation looks short, you can see in the CBCT there is a solid barrier formed in this tooth, and in the other tooth in the radiograph it appears beyond the apex, but it's actually at the apex. You can see the barrier formation here. What's also interesting to note is there's something like a periodontal ligament which is formed around the barrier, both in this tooth as well as this tooth. So yes, a pretty interesting case.